thanks everybody for joining the Pediatrics and Family Panel discussion. Again, I'm Rob Karch and joined by Dr. Sarah Messiah and Dr. Jacqueline Albin. Loved your talks, both of you this morning or this afternoon, earlier today. And for those who may have missed them, just to recap, Dr. Messiah really laid out the problem and spoke of the epidemiology of pediatric obesity in the US, defined pediatric normal weight to overweight obesity, because it is different in the pediatric population than the adult population. We define it differently clinically, and I think that's important to understand. There was a question that we'll get to on growth charts, pediatric growth charts. Obesity through the life course was a major theme. A concept that's very important to me as a pediatrician is the childhood onset of adult disease, and hypotheses like the Barker hypothesis. This is why I went into pediatrics, was to try to nip it in the bud before it became a problem in our adult population, whatever it may be, that we're focusing on. So that opportunity to get to prevent problems is my interest in pediatrics and in public health, for that matter. This concept of the first 1,000 days of life, so important. We've heard about this, for a decade or so now. The 9 months of gestation and about the first 2 years of life, and what happens in those first roughly 1,000 days of life really sets the stage for a lifetime, as evidence is showing. All the medical comorbidities associated with this sad state of pediatric obesity that we can see, and some of these diseases, which were diseases of adulthood prior, not too long ago, have now come down into the pediatric age group. Some of the barriers and strategies to prevent obesity. And then Dr. Albin, she mentioned that culinary medicine brought her joy and is the joy in her professional life. I feel completely the same after years of working in pediatric obesity clinics and even endocrinology clinics and general pediatric clinics. This idea of a triad between chef, physician, and dietitian, and that power that triad brings to health promotion and disease prevention is really, I think, where the rubber meets the road, and it is the way forward through a seemingly impossible problem to tackle. This double burden of malnutrition that Dr. Albin noted, undernutrition and overnutrition, and in some cases, countries exhibit both. Under and overnutrition. Food insecurity in the United States. I found that it's only a matter of just scratching the surface, asking the questions of the family that's in front of you, and surprisingly frequently you'll find food insecurity if you simply ask. And it's incumbent upon us as clinicians to ask those questions and even have those questions screened on admission to hospitals, in clinics, and so on. Supporting families, meeting them where they are, all the things that Dr. Albin mentioned, family meals, the benefits of responsive feeding, modeling healthy choices. Again, Ellen Satter was brought up, and the roles, the responsibilities of parents and children, and that concept. So a lot of the questions that were asked discussed, what resources were available. These are some of them, and we'll get to all the great questions. We'll get started now. If you do have additional questions, please put them in the Q&A section. I'll be checking those. But I thought we'd start with just a basic question, and Dr. Messiah had gone over the definitions of weight status in children based on percentile curves. The first question was, can you speak about the differences in the CDC versus the World Health Organization growth charts, and consider strengths and weaknesses of both? Dr. Messiah, can you start with that one?
Sure. We use the World Health Organization growth charts for babies from 0 to 2 years old in the United States. And they're based on recumbent length. So before children stand for height, they are based on a healthy population of about 6 countries. One is the United States, and it was assumed that healthy included breastfed children also. Whereas the CDC growth charts are based on a population of United States children from about the mid 60s to about the mid 80s, 90s. So we can't assume those children were all breastfed, all healthy. So they are different. And that for that reason, as an epidemiologist, we are told you'll see you can't really compare either the recumbent length to height because of that. And they are different. So obviously here in the United States, we use the CDC growth charts in all, you both know, in your clinics with your patients, because that's the referent population in the United States. So
generally after age 2 is what, we'll use WHO growth curves up to age 2, like you said, when length is measured, and then height after 2 up to 18. Weight for stature, weight for height. Thank you.
You're welcome.
Dr. Albin, what good sources are there for recommendations for busy primary care practices, for strategies, programs for our families? So as a busy clinician, where do you refer your parents?
So I think that's the $1 million question. I'm not sure I will solve that for you, but I think the step that we all have to take is to just bring up food. And that is what most people are skipping over. It doesn't require a fancy resource to endorse the fact that nourishing food is playing a big part in a child's health. And when I work with residents, and this is true on the full med-ped spectrum across both internal medicine and pediatric training, they often will list for me all of the patient's health concerns. And in an adult world, it's high blood pressure, it's diabetes, it's fatty liver disease, it's heart failure. And they'll say, I didn't have time to talk about food. And they know to tell me what they said about food now, because they've all learned. I'm going to ask, like, what did you talk about related to food? Did you screen for food insecurity? And they'll say, I didn't have time. And I'm like, but you also don't have time not to talk about the unifying thing that influences all of their health conditions. And so same for pediatric population. Is it a behavioral problem? Is it tantrums? Is it constipation? Also all linked to food in different ways. And so the message that I guess I would give is that we don't have time not to talk about it. How we talk about it matters, but as I said, we are not the solution just in the healthcare space. We just have to endorse and elevate that food matters for health. We have to make that connection for people. And I often align it to smoking cessation, where your patient is going to have to be the one to make the choice about when they're ready to make smoking cessation steps. You're the one who says, this is one of the most important things you could do for your health. And so I do the same thing with food. And then back to some of the stuff I tried to emphasize in the talk is that it's those specific ideas and advice. I actually keep a ton of the Health Meets Food and other recipes in a distribution center right outside the clinic rooms. And so I'll actually prescribe 1 or 2 recipes for people to try after a conversation that's maybe just 1 or 2 minutes related to the food struggles they're having. So keep it simple and emphasize why it matters, because that will inspire families to go looking for things that fit their situation. And you can create a list of websites or local programs that are helpful. Our library is a great resource for nutrition information because they have a repository of resources. So you have to figure out what that looks like for you locally, and then just make 30 seconds to 2 minutes a priority to bring it up at every visit.
And you mentioned earlier today to just even a brief dietary history from what they ate yesterday and focus on one small change And that's a basic tenet of culinary medicine. I see here in the chat, when I don't have time for a more detailed history, I just ask how many vegetables they eat per day. And that's a good example of, you know, a small change, maybe focusing just on that. Eatright.org is a good resource that I use. And in terms of resources, again, basic tenet of culinary medicine, if you can, try to work with a registered dietitian. I don't think anything is as valuable as having a dietitian in your clinic that can reinforce, that can discuss at greater length than you're perhaps able to in clinic. And then if you can, have a chef. And you know, we're starting to see practices, even, it's not unheard of, to have you know, clinics affiliated with a chef and a dietitian, so that this concept of the triad in health promotion is really quite powerful. How does the prevalence, Dr. Messiah, of obesity vary by ethnicity? You referred to that a little bit in your talk.
Unfortunately, we have major and deepening and widening disparities with non-Hispanic, Black, and Hispanic youth having higher prevalence estimates of overweight, obesity, and especially severe obesity now for both boys and girls versus non-Hispanic whites, and definitely versus Asians too.
Yeah, yeah. Wonderful. Thank you. Thank you. Dr. Albin, what suggestions do you have in discussing weight challenges to those parents who don't consider their child to be overweight or challenged by weight?
Yeah. So I think this is highly sensitive, and I err on the side of healthy lifestyle choices as the pattern, because and this is particularly true in treating adults and in treating children with a history of trauma. Making positive shifts doesn't always lead to the weight loss that people hoped for. And at the end of the day, though, the win is the positive lifestyle change and the improvement in metabolic function, which may or may not always come along with the weight changes that people are hoping for or looking for. So I actually de-emphasize making the conversation about weight anyway. I typically just show parents the growth chart and, you know, make a statement about how this is not a perfect measure, as we've already talked about, but here's where we like kids to fall, who are going to have the best chance at optimal health. But here's where your child falls, and I would love to talk about some ways that we can help shift them towards a healthier space as they grow. And the age of the child really matters. So if it's an older child or a teen, I'm definitely going to be very sensitive and careful, because we do not want to induce disordered eating by the way that we talk about this. I've had people come to our clinic from other practices who literally left a practice because a pediatrician said something like, your child is fat. And it was so disruptive and upsetting to them when they felt like they were really doing their best and they didn't feel supported. So I think it's really, we have to be really careful here. So it goes back to what the motivator for the child is going to be. If they're older, what do they care about? What are they interested in? And can you link healthier food and activity choices to helping them be successful at what their goals are, at what they're interested in? And it may take time. These things this is part of the beauty of primary care. It's an iterative process. Like, I don't see you once, I see you 50 times. And we might not get to where we want to get in the conversation until visit number 5 or 7 or 20. And we just keep trying to lay the foundation of positive shifts.
That's right, and that's what we talk about in culinary medicine all the time, right? You know, make this small change, we'll see you back at the next visit, and advance. And we do have the benefit of seeing patients over and over again. Now, this question gets back to the resources here. This particular person is in a small rural community, far away from, resources. Are there good virtual resources like this conference that you would recommend? Dr. Albin, do you have?
Oh, so specifically for families or for
I think, well,
people
you had
caring?
mentioned that you printed out recipes from the
Yeah.
Health Meets Food website. I'd do that too. That's I would actually start there if we're talking about recipes, ideas, building a healthy breakfast, for instance. It's a great resource.
Yeah, I think make it about food and not too complicated. People need us to talk in terms of like what's for dinner tonight or what is a healthy breakfast, and just trying to get at their pain points. And I don't think we need. I loved how Dr. Nessel brought up what I've been sensing is that we've just made this really complicated, and it's not actually that complicated. That avoidance of ultra processed foods and increasing our as many whole and plant-based foods as possible into our diets is going to lead to improvement. And we're not looking for perfection, we're just looking for better. So we just need to give people ideas. And I find just with a lot of the communication I get from folks on Instagram, that just a very simple picture and description of an idea for how to incorporate a healthier food into a family's pattern is all most people need to make a shift. And then it creates this trickle effect. It's the power of habit that you begin to say, oh, that wasn't so hard, I can do that again. And they have self-efficacy that builds over time. So the definition of the best or perfect resource, I don't think it exists, because I'm always looking for online resources. You find any website where you think there's great recipes that are accessible for people in your community that are culturally relevant, and then print some out, have them available, and just talk about food for a couple of minutes. And someone also posted My Plate as a great resource for recipes.
myplate.gov and dryum.org. I believe I saw her at a conference once.
Yes, she's a pediatrician. Yes.
And now here's a common scenario. Parents aren't on the same page. Mother eats healthfully, but father won't, and two separate meals are being made. This is a common scenario. What do you, how do you approach that?
It's kind of like any patient care problem where the whole family's not on the same page. I try to actually get them to all come in and say, hey, at the next visit, because parents, by the way, if you're a parent and your spouse takes the kid to the pediatrician, they're probably tattling on you about something. Like parents always tattle on the other parent to me. Like the sleep problems are dad's fault, the eating problems are mom's fault, or grandma gets blamed too. So I think getting the family on the same page might take a little bit of a speech. And I will oftentimes bring families in and say, look, you guys have to be consistent in your messaging, because children are really good at playing caregivers against one another. And they'll know, I got to ask mom about this because she'll say yes, and dad about that. And so we want to try to minimize that. Caregivers have to commit to getting onto the same page. And I would directly tell parents, your modeling is critical. And even the little bit of data that I shared about dads, that coercive feeding and poor modeling have direct implications for that child's lifelong eating pattern. And not that you want to guilt trip them, but you want to empower them to say, what you do matters. Your kid is watching and it matters. And you have this amazing opportunity to set them up for success. And how can I help you be successful too? Because it's going to improve your own health while you're taking care of your child's health. So it's tricky. And I hear that a lot, that families are not always on the same page.
Yes, thank you. Please repeat the website that I just said for great recipes. I believe, and Dr. Harlan, please correct me if I'm wrong, www.culinarymedicine.org. And that'll take you to great recipes by breakfast, lunch, dinner, snacks, great variety there that we use in our class all the time. Dr. Messiah, at the Obesity Medicine Conference, there was talk of having different BMI cutoffs for certain ethnicities. As a pediatrician, I've not heard of growth charts being adjusted for different races, ethnicities, but only for certain medical conditions like Turner and down, et cetera. Can you speak to that?
That's a great point. I've advocated for that for years. We actually published a paper a decade ago on waist circumference, ethnic specific cut points circumference, because of different phenotypes, and how different children from different ethnic backgrounds carry fat distribution differently. And therefore, should we be having the same scale, the same reference for all children? There's definitely argument for why we should be thinking perhaps about ethnic specific cutoffs. For, you know, BMI is controversial in itself. Obviously, it's not a direct measure of fat composition, lean composition. It's the advantage is that it's an easy measure to take, especially for a lot of us who are doing community-based work and need to train people in the community to do anthropometric measures. It's easier, it's more cost-effective, but it is controversial at the same time, because obviously there are children that fall into, say, a category that would define them with obesity, and they aren't obese. Athletes is a classic example because they carry a lot of muscle mass. So yes, I do think I do think there's a lot of especially as we become more diverse as a nation, a lot more that should go into thinking about perhaps ethnic specific cutoffs for BMI and even waist circumference or waist to hip ratio and so on.
Thanks, Dr. Messiah. This one was, I saw this, how much weight gain in menarche is healthy? Yeah, do you want to, I have some input there too. Do you want to start, Dr. Messiah?
Yeah, that's always a tough one when we're working with, especially like the 10-year-old to 14-year-old age group in the community, and we are doing a one-shot day of measurement, and you never really know where that child is on the spectrum of menarche. So you can catch them as they may be going through that spurt of gaining a little bit of weight before they shoot up in height. You may get them on the tail end of it. So I'll let you comment on that more.
Yeah, I think the answer is to just really still rely on the body mass index and the guidelines and the norms that are established for children, because there's height, you know, what's the child's height? There was a study where you know, there is still some weight gain and growth after menarche for sure. But I think in terms of defining a healthy amount of weight in pounds or kilograms really isn't, we don't have that. Just trying to keep weight within the healthy BMI percentiles, I think, is the answer to that question. There was a study that showed about 6.5 kilograms of weight gain, about 14 pounds after menarche until the age of 18 that I came across, but that was on average. So, okay. Would you please comment on the roles of dietary sugar as the primary driver of metabolic syndrome in children and adolescents? The role of dietary sugar.
Is Dr. Lustig on the line? He can probably go to town on that one. And you probably don't want me starting on sugar, but as well, because I think but it goes back to thinking about how we introduce food palettes to babies also. If you look at how we think about what's the first food that's introduced, how come it's always seems like it's something sweet and not a vegetable or something that may not be sweet. And so you just think about the very, 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 very early in life. And what is the science behind that? Because I've heard from so many of my students from India in particular about how they actually promote introducing spicy foods when mom is breastfeeding, spicy foods as the first solid foods in children. And we do just the opposite here. So I often wonder if we're just setting up children to automatically want that sweet all the time. I mean, it goes without saying, sugar's in everything. And there's lots of studies that show it mimics cocaine and heroin in the brain, and how it behaves too. So you want more and more in that addiction pattern. So
Yeah.
Dr. Alvin, you want to comment?
We really we set up kids for, oh, it's your birthday, here's something sweet. It's your friend's birthday, here's something sweet. You got a good grade, here's something sweet. You had a bad day, have something sweet. And I really think we condition ourselves to use that as like a drug of choice, as a celebratory and comfort drug of choice. And that in small amounts, in moderation, with mindfulness, in appropriate settings, it's okay to occasionally have a piece of cake. But we've made it such a ubiquitous thing where multiple times a day, we're faced with making choices about consuming typically ultra processed foods that are high in sugar. And of course it's overwhelming our systems. And so how do we reset that? And you know, I do it. I'm like that mom that has a table full of produce and maybe some fresh popcorn, and then everyone gets a small little treat to take. And typical birthday parties for children, there's 4 different treats and every child there is eating all of them. And I've coached and trained my kids that when we go to other people's parties, we choose one treat, and the juice is a treat, the cookie is a treat, the cake is a treat. Like, we're not going to eat all of them. And so I think it takes a lot of intentional countercultural movement, and you just got to keep plugging away in your own environment. And I've actually already made some changes at my kids' school just by writing a little bit of a proposal to the school about why do all of the sort of reward baskets have to be food based, and can we make a shift? And I will literally buy you dollar store prizes to fill those up instead. And so I think we've got to denormalize constant sugar exposure and not make people think we're completely taking it away from them either, because then that's where people revolt and they don't listen anymore. So it's got to be this balance, and I'm sure we'll learn more about this from Dr. Lustig tomorrow.
Now that it's added to food labels, do you discuss with your patients added sugar and where to find it and how to read a basic food label?
Yeah, I do. And I actually teach kids this. My kids started being able to, you know, I give them the American Heart Association recommendation is that we don't have any more than 25 grams of added sugar in a day. So if you eat that yogurt, and it's my job as the parent to make sure that the foods in the house are reasonable, right? So if there's a yogurt with added sugar, I never buy one with more than 10 grams. And if you look on the shelf, there's a lot that have 15 to 20 grams for a single yogurt. So you want to try to shoot for like 6 to 8 grams of sugar added or less in most foods. And so maybe even something that's a minimally processed muesli that's better than a lot of other cereals. You got to check the sugar on all the labels. And both of my kids, I don't manage it. They're 7 and 9, and they self-calculate their sugar intake for the day. And they'll tell me, I'm not going to have dessert tonight because I already hit my 25 grams today. And I don't control that. We just have empowered them that it's the best thing for their body. And it takes a lot of intentionality and modeling from parents to do that. But I think you teach a kid and then they can become independent of their parent, even when there's not great modeling, if they're motivated to be well. But it is an uphill battle because it's not culturally normative.
Yeah. Yeah.
How do we shift that, right? How do we make it cool to focus on nourishment.
Mm-hmm. Thank you. Thank you. Dr. Masai, I think you ended your talk saying that we assume everyone knows how to prepare nutritious and delicious meals. I think that was you, and that really gets to the heart of food, teaching about food, what is healthy and how to deliciously prepare it. Do you talk, and this is really my question, do you discuss with your patients, clients about meal planning? Such an important concept. I think the key to healthy eating is really planning meals, given the real life constraints of time, budget. We all have busy weeknights. You know, how do you avoid these ultra processed foods that Dr. Nessel talked about? Well, one of the ways of avoiding them is to prepare ahead of time and reheating during a busy school night what you've prepared earlier in the week, batch cooking, repurposing. How are these concepts, shopping lists, how do you discuss these items with your patients?
They usually come up because the parent starts talking about their own health issues. This is the first generation of parents now that has grown up with the obesity epidemic, and now they're starting to have children, and so they grow up in a very fast food culture. So a lot of them will tell you, we just never really learned to cook. And so it's like going back to the basics, like you said, a lot of the strategies you mentioned, even this is why this conference is so key, because just introducing cooking and the love of cooking to families, you have to start there. But I will say, where we get a lot of pushback is with parents, especially in low-income neighborhoods, saying, I don't have the time, I don't have the resources, I'm too tired when I get home, I work 2 jobs, it's much easier to go through the drive-through, and so on and so on. And that's where you have to really, really sit down and do the work and show them it's really not that hard. Like you said, you can use 2-3 ingredients, throw them in a slow cooker even, and have a meal that's cheap and nutritious at the same time. So, but it's not just a one-off either. Like Dr. Allen said, it is repeating and repeating. And it's hard work. It's really, really hard work. And the communities that I've worked through in my whole career are incredibly multicultural too. So you have to always be thinking about being culturally sensitive, culturally competent, and what are people comfortable with eating that is going to not only keep their culture beliefs and feel like they're eating from maybe meals like they prepared from their home country, but make them nutritious at the same time. So we'll do a lot of things like thinking about changing to a healthy fat to cook in for a homemade recipe, having the parents bring the recipe and then working with them to adapt it to make it healthier, rather than us giving them brand new recipes to work with.
Mm-hmm. Thank you. It just flipped down. I saw an interesting comment here. Again, concurring with Dr. Messiah, I've wanted to do a deliberate study project with cultural backgrounds and patterns of infant food introduction to see the longitudinal outcomes in different outcome measures, such as behavior, school performance, and obesity. There is the Feeding Infants and Toddlers study, 1 and 2 FITS, that looked at that. But yeah, a lot of this is relegated to culture and tradition, right? But we're starting to get some good evidence on optimal early infant and toddler feeding. I think that anybody in this conference, again, speaking to the choir, but why should healthcare providers care about this? I think this is kind of a softball, but you know, why should busy, and that's busy healthcare providers take the time to do this, to discuss this with their patients, and what are some of the resources and strategies? I think we already talked about some. Dr. Albin, just again, why should we care about healthy food and discussing that with our patients?
You know, we all took it very seriously when I walked across a stage and signed an actual book with the Hippocratic Oath on it, part of which is to do no harm. And I personally, before I came into the food as medicine movement, I felt like I was doing harm by not knowing how to emphasize this, how to help people. And particularly as an internist, 20 prescriptions for a single patient who's not getting better, they're getting sicker. Like we talk about insulin as a treatment for diabetes. It's not a treatment for diabetes. It's a band-aid for hyperglycemia that actually worsens the pathophysiology of diabetes. And, you know, I'm not anti-pharmaceutical drugs. I use them all the time, but it is really unrewarding to see people getting sicker and sicker and losing their quality of life and feeling powerless over it. And to me, lifestyle and culinary health are the solution. It's not an easy solution to implement because we're going backwards against, you know, what has taken decades to develop as cultural norms that have made us very unhealthy. But I can't not talk about it because I feel like I'm doing harm if I don't help people know there is a way to be free from most of the chronic diseases that plague us and take our quality of life. And so that's the why for me. It's and it, you know, again, it brings a lot of joy to see people successful, not because of the pill that I gave them, but because of something they did. And it's really not, I'm just a coach. I'm not there to heal them. They're there to heal themselves. And people find that really, really empowering.
And I think it's just wonderful to see families, you know, when we do our community sessions, you know, a child who wouldn't have, you know, looked at whatever vegetable you have, but then again, once they're involved in chopping it up and cooking it, tasting it, talking about it around the table, them liking it and, you know, making it at home, and then discussing it the next week when they come in, that they actually incorporated it into their, you know, kitchen routine. That is amazing. And you can see it in just even a couple of courses in culinary medicine after a couple of sessions. That's very, very good. I'm trying to make sure we've, Dr. Albin, have you found that food pantries still have a high number of boxed and canned items, less perishable items in food pantries?
So I'm going to speak, I can speak about my local experience. And if you guys want to check it out, you can go to Crossroads Community Services, Dallas. They have an extremely innovative model. And I think we need more innovative people in the food banking system. But part of the struggle is, especially if you're covering a wide area, having access to the freezers and the fridge space that allow for a lot of produce and perishable foods is something that many of the distribution centers that are in smaller areas don't have. And so actually with the approach that they take is kind of as a hub, and they prepare and store all of the foods and have massive storage space for produce. And then they have what they call community distribution partners that do not function as full food pantries or food banks, but there can just be little church kitchens and community organizations that are right in the midst of a group that needs their support. And they have a certain amount of time, which is usually about 2 days, to distribute the food after it's given. And it allows them to do so with a a lot less storage requirement. So those types of innovations are really important because it allows us to get more of that fresh food. The foods that we have been able to get, in fact, actually, we're doing a randomized trial right now with an underserved population at our Parkland County system, looking at culinary medicine as an intervention for patients with diabetes. And everyone in the study, both the intervention arm and our control group, are getting food from one of our local food distribution sites, and we get to pick what's in the box. So if I say I want oats, I want beans, I want fruits, I want veggies, they can order those things. And I think that a lot of people imagine food pantries as everyone's like leftover highly processed foods. And yes, there is still some of that, but as more and more emphasis and investment on this, the importance of this resource is happening, there's a lot of promise in this as a source of really high quality foods for many people. And I would encourage you, get involved in your area, because I'm actually one of the people that helps them determine what they need to order just because I volunteered. They are open to the voices of clinicians, physicians, dietitians to support the quality of the foods that are ordered.
Thank you. I'm here in Central Florida, and there's the Second Harvest Food Bank, and they're actually creating their own line of foods. They're going on the offense, actually, and I think it's wonderful. They have a phenomenal culinary training program where they will offer a culinary medicine course upon completion. They're already well on their way to getting a culinary degree from the local community college, Valencia College. And then Valencia has a well-established program with all the theme parks in the area and the massive hospitality industry that's here in Central Florida. So it's really a job creation program, but they're also creating their own line of food from the food bank that they're selling locally, and using the profits to bolster the food pantry. Here's one. Do your fellow moms feel like you judge? Do moms feel like you judge them? How do you prevent that? I think you spoke to that, Dr. Albin. How do you deal with the parent who feels like you're judging them?
So I put in the chat some comments in response to one of those questions, and I'm a lot more open and passionate with this group. You have to be very cautious when you're like a mover and a shaker in your own community, because people perceive judgment even when it's not at all the intention. And I sort of view most people as a victim of the culture, not as individuals who are making bad choices. And I think we have to sort of reframe our thought, and modeling better behavior without talking a lot about it is really, I think, the most effective strategy. And then you will get people who are curious that will ask, and then you share what you're passionate about by their asking. And I'll give just a recent example. I have a friend who had major surgery, and the moms at our kids' school all signed up to take meals. And what I took involved a lot of chopping and a lot of produce, and a meal that would be compatible with some food allergies that they had. And she texted me later and she said, what's fascinating is that when you've had surgery or you're recovering, people bring you comfort food. And I got tons of desserts and pasta dishes, and you were the only one who brought me mostly produce, which is the healing food that I needed. And I never realized that before, when I was the one giving people food who just had surgery. And now I'm going to change what I take to people because I experienced that myself. And so, I didn't say anything about it. Like, I just took what I would want to eat for dinner. And so those little shifts, now she might be that person too, who thinks about how can I bring nourishing foods to someone who's healing or recovering instead of comfort food, because we get way too much of the comfort food. And then to just very quickly address the question that someone said about what do you do when a patient or family says, I'm not doing that? You don't spend a lot more time today. Again, I take it back to smoking. It's the stages of change that people who are totally pre-contemplative, the data shows that we waste our time if we dive too deep into that. I would just end that conversation saying, I'm super passionate about the role that food plays in our health, and I'm here to talk about it if you ever want to. I have a lot of thoughts and would love to support your family in that. And then just move on.
Yeah, agreed. Do you use social media at all? There's a question here about use of social media. Any thoughts on that?
So that's an individualized decision. I think just like everything we do, you have to ask what your mission is. Are you hoping to become an influencer? That is not me. I don't have the energy to maintain an influencer social media account. I've seen what it does. Actually, one of my medical students, I'll put her Instagram in the chat, has a lot of success as a social media influencer, and she is a little bit overwhelmed about it, and has had to process that while being a medical student at the same time. My goal is simply to just be a source of evidence-based content, because one of my complaints is that there's not content out there that's people can easily find that is evidence-based. And so I state my credentials as a physician and a certified culinary medicine specialist and a mom, and then I put food content out there. I keep all external facing social media, which is my Instagram and Twitter, non-personal. So I don't post pictures of my kids or their faces or tell a lot of personal stories that aren't directly related to either food or the policy changes that I'm advocating for. And so I think we each have to decide, like, what is our comfort level. I keep my personal social media, which is Facebook, not public. And so each of us can decide what's our mission and then what's our approach. But I do think social media is something that has a powerful impact. People want those little nuggets, those little sound bites. And so it's a way to put content out there. Everyone who's not evidence-based is doing it. So we probably need to be doing it too, so that we can counteract some of the misinformation.
Yeah, yeah. Dr. Masai, you talked about the family-based model and the fact that so many families have multiple generations in the household, perhaps grandparents cooking, and that can be a problem. It can be a real barrier to behavior change. How do you approach this multi-generational aspect of food in the household?
Yeah, it's a big challenge, as are divorced families and working with two separate households. We had both of those challenges in a recent NIH study that I just finished up in Miami with Hispanic families only. And we would encourage the grandparents to come to session, get some exposure. For this study, it was a 3-month intervention that included actually a lot of cooking classes, a lot of physical activity classes in the park system there. So we would learn quickly. We asked about who was living in the household and who was responsible for making nutrition choices, shopping, going for physical activity, and so forth. And if there was a grandparent or another relative, and a lot of in my non-Hispanic Black families, many times the grandparents are raising the children in inner city communities, unfortunately, because the parents are in prison or have died. So we had a lot of families where the grandparents were raising their grandchildren. We would ask always that they become involved. But in the case of if it's multi-generational, definitely involving them as much as possible and learning more about what is the role. And in a lot of cases, it's because parents were working 1-2 jobs and weren't home in the early evening to cook. They the grandparents would pick up the children from school and cook. So we would intervene at that level as well. Mm-hmm. But you have to assess it first. You can't just assume that everybody's in a nuclear family. I mean, half the time it doesn't look like that at all.
Right.
So it's a very important point.